Well, I know we're getting started a bit late today, but I want to welcome everyone to another edition of PMP Pals Hope Zoom. We do have a large number of attendees today, so we will be following the webinar format and muting all of the lines except for a select few. But we are super excited to have Dr. Joseph Misdraji here today from Mass General to talk about the pathology of PMP cancer. So super excited for this topic. As we start the webinar, I do want to show you some information and make sure everyone understands this format. So some things to keep in mind as we go through the webinar today. We are not licensed to provide medical advice. So PMP PALS has been here since 1998 to bring together cancer patients for support and teach them how to advocate for themselves, but we are not licensed to give medical advice. Some of the images and data you see today may be scary or graphic, so please keep that in mind. And as hard as we try to keep this an anonymous forum, we cannot guarantee that. So keep that in mind as you're participating in the forum. And then finally, by participating in this, you do grant us permission to share your likeness with the general public. Our whole purpose is to get information like this out to cancer patients and caregivers and help them benefit from the information. So with that, we'll go ahead and get started. And then we'll start with introductions. Again, I'm Chris Piekarski, the president of PMP PALS. I'm a 16-year survivor and am here again. Just this is the highlight of my week being with you guys. So thanks for being here. Adele, do you want to introduce yourself real quick?
Yeah, likewise. It's the highlight of my week as well. Adele Jason, PMP PALS vice president, and I am an 8.5-year survivor.
That's great. And Michael, I can't find you. There's so many faces. I've lost you on the screen today. Do you want to say hello and introduce yourself?
Hi guys,
Okay.
Michael Healy from the south coast of Ireland. I'm an 8-year survivor, surgery in Basingstoke in the UK, and I'm one of the admins on the PMP support group Facebook. Nice to see everybody.
Thanks, Michael. James, you want to introduce yourself?
Hello, I'm James Caldwell from Northern Ireland, about 10 miles outside Belfast. I'm a 6-year survivor from a high-grade mucinous adenocarcinoma. Just had a CT scan result today, which is NED. So all good.
And Charmaine, did you want to say hello? Lower left-hand corner, you should find, there you go.
I'm Charmaine. I'm a board member with PALS as well. I'm a 22-year survivor at Austin, Texas. Nice to see everybody again.
Thank you, Charmaine. And Dr. Lambert, we do have a special guest who we snuck in here today too. Dr. Lambert, do you want to say hello before we turn to talk to Dr. Misdraji?
Oh, hi, I'm Laura Lambert. I'm a surgical oncologist at the Huntsman Cancer Institute in the University of Utah in Salt Lake City, and I do HIPEC surgery, so great to be here.
So we love all of our specialists, but we do have a particular fondness for Dr. Lambert. She has a great bedside manner, and we adore having her as part of the team too. So great to see you, Dr. Lambert. Dr. Misdraji, it's nice to have you here. How are you?
I'm doing well, actually. Thank you very much for asking.
Good. Now, I'm not faking my excitement in meeting you and having you here today. So as a 16-year survivor, I was working for a pharma company when I was diagnosed. And so I had access to a large library of literature. And so there's a couple of names that come up in the pathology of PMP, and your name is one of them. So I really am excited to meet you after reading your papers for so many years. So thanks for being here.
Welcome.
Great. Well, you know, the pathologists work in the back of this workflow and the process with patients. So it's rare that we get to meet them. So it's really special. So it's great. Now, you had created a presentation, I believe.
Mm-hmm.
And if you'd like to walk through that presentation, we are going to be all ears today.
Okay, everybody. Well, hello. I hope everyone's doing well, not just with what you're currently dealing with, but of course we're all dealing with a pandemic on top of everything else. So this is why we're enjoying each other's company in little boxes. So I'm going to try to share my screen, and hopefully this will work, because I was responsible for the technical difficulties earlier. Okay, so I'm hoping you can all see my presentation.
We can.
Okay. So I'm a pathologist at Massachusetts General Hospital, and I do gastrointestinal liver pathology primarily. I'm now the director of the gastrointestinal pathology section. And I've had a long-term interest in appendiceal mucinous neoplasms. And so I was going to go through the pathology of those neoplasms and the pathology of Pseudomyxoma peritonei. And let me start by saying one thing about this particular area of study, which, unlike most areas of study, I think, in cancers. And that is, and you'll see how this sort of bears fruit when we start talking about it, that Pseudomyxoma peritonei we recognize as the metastasis of a mucinous tumor. Usually that's from the appendix, although not always, but it's most relevant when we're talking about the appendix. And yet it's actually been studied separately by different people. So there are people who have taken a particular interest in the tumors of the appendix, and a separate group of people, especially years ago, who were more interested in Pseudomyxoma peritonei. And so there was a little bit of lack of crosstalk between these two disciplines, because Pseudomyxoma peritonei actually was initially more of interest to gynecologic pathologists and not gastrointestinal pathologists. So it's really in the last 20 years that those two fields have been unified, and there's a little bit more attempt to have those two disciplines talk to each other and have it make sense from the appendix tumor that produced it to Pseudomyxoma peritonei. So we'll see how that complicates some of the nomenclature over the years that was mostly introduced by pathologists, actually. So I'm going to just start with very basic stuff. I know many of you know this because it is somewhat basic, but just to make sure that everyone's on the same page, this is a cartoon just to show us that this tiny little organ that hangs off of the ascending colon and the cecum is the appendix. And this tiny little organ is sometimes, while being very small, the subject of a lot of mischief. Here's a relatively normal looking appendix. It almost looks like a pinky finger. Here's where it was attached to the colon. And you can see that there's this sleeve of fat where the blood vessels would run through it. And this is actually the appendix here. And again, it just looks like a pinky finger. When we look at the histology of the appendix, there's a little bit more to it on the outside, but I want to focus on the inner layers. And it's kind of like an onion, and it has layers with the wall and the lining of the organ, but this is the exact center, and this is what this layer is called the mucosa. And we can see here, this is the mucosa, and it's made up of glands. These are glands, and this is the luminal surface. So there's some stool. And this lining is the epithelium, and you can see that the appendix is well known for having a lot of lymphoid tissue. So these are immune cells, and so one function of the appendix might be that it's to teach the immune system to handle bacteria within the fecal stream. So this is a normal appendix, and now we're going to take a look at an abnormal appendix, and this is an appendix that might be called a mucocele. A mucocele just means a dilated structure filled with mucin, and of course this does look dilated, and you can see that there's a lot of this mucoid material in it. This is an old term that was used in historical literature a lot to describe tumors of the appendix. Today, we don't use it that often. It's recognized as being more a descriptive term. So if I were to see this, for instance, the way you're seeing it now, I would say, oh, this looks like a mucocele, a dilated appendix filled with mucin. But it doesn't tell us whether this will ultimately be a tumor, an invasive tumor, or even just a blockage of the appendix that produced an accumulation of mucin. Now, this is an example of one of these tumors that might be neoplastic. And you can see that we have mucosa has changed here. So this should be the same as it was before, but now we see that instead we have this transformation of the appendix lining into these fronds, these structures that look like what are called villi, very thin, elongated structures. And this is a comparison from that first picture. This is what it should look like. So these are tubules going into the wall, and instead these are more like finger-like projections going into the lumen. This is actually the same type of tumor, but sometimes the accumulation of mucin within the wall causes it to become more flat, and the villi are lost, and we're seeing these little tufts instead, or a single layer. But this is actually the same type of tumor. So here's an appendix that's dilated. It looks like a finger that someone took a hammer to, and it's really bulbous. And there's this little plug of mucoid tissue here with a little bit of hemorrhage around it. It seems so innocuous. So most of it looks like a sausage that looks intact, but this little plug of mucin and hemorrhage is the sole area where it seems to have been breached. And here's an example of an appendix where the tumor has breached the wall. So here's the lumen, where you'd have the fecal matter within it. Here you can see it's one of those examples of a tumor that's just a thin little layer, so there aren't really the villi that you see in some tumors. This pink is the wall of the appendix, the muscular wall that squeezes the colon like a tube of toothpaste to keep the fecal stream moving. And you can see that what's happened here is that it's burst. This part is open, and this kind of gray pink material is mucin, and it is extruding onto the surface of the appendix. And that innocuous looking little hole has allowed the tumor to escape into the abdomen. And this is the omentum. This is the transverse colon. This is the segment of colon that's going from your right side of your body crossing over to the left side of your body. And there's this piece of omentum that should look like fatty tissue. It should look a little bit like chicken fat. But you can see that instead of looking like yellow little fatty deposits, instead we have this kind of pink mucoid material clinging to it. And here's another area, and you can see rather than looking like something that you would say looks like chicken fat, instead this almost looks like bubble wrap. This looks like dense bubble wrap, and here it is cut in half, and you can see what the cut surface looks like. And again, you can see that it looks very spongy and glistening, so it's mucoid, and it looks like a bunch of little cysts almost. And when we look at under the microscope, this is what we might see in Pseudomyxoma peritonei. Now, what we should see in the omentum is a lot of fat, and fat just looks like a little white circles. And you can see that instead, we see these lakes of this gray material. This is all mucus. And floating within it, you see these strips. These strips are the epithelial cells. These are those same tumor cells that were lining the appendix before are now swimming inside these lakes of mucus. And they continue to produce this mucus, which accumulates in the abdomen. And that is the phenomenon that we know clinically as Pseudomyxoma peritonei. Here it is on higher magnification. This gray material is the mucus, and you can see that we have these floating strips of glandular cells. Here's a little gland, and here's some more. And these continue to produce mucus, and it's kind of a strange phenomenon how they are able to grow in this mucus without blood vessels, without oxygen supply, but they are able to continue growing in the abdomen to continue to produce the mucus that we call Pseudomyxoma peritonei. In women, it's not uncommon for this tumor to go to the ovaries. And in particular, the appendix lies closer to the right ovary. And so the right ovary is more often involved than the left, but not always. Now, an ovary, if you cut an ovary, it should look kind of like a parsnip, I would say. Like if you cut a parsnip and looked at it. And you can see that that's not what this looks like. This, again, looks like jelly that has filled up this ovary. It's been cut open, and this jelly is just pouring out of the ovary. This is the normal areas of the ovary. This is what we should see in an ovary. What we should not see are these glands, these pale glands that are traveling through the tissue. And you can see when you look at higher magnification, these cells look very similar to the ones that were in the appendix. And so essentially this is involvement of the ovary by that same appendiceal tumor, and this is a frequent phenomenon in women with Pseudomyxoma peritonei. Now, to discuss why this tumor has gone through so many names, has been so controversial, and only now is achieving some sort of uniform terminology, I want to, for a moment, detour into a different sort of cancer so that you can see what is a more typical, easily interpretable phenomenon. And this is a colon. Here is a little bit of what's left of the small intestine. This has been removed. So remember that the stomach goes into about 6 feet of small intestine. It ends here. So a little bit has been removed, and then it moves into the large colon where water is removed from the feces and you get stool. And here's the right colon. It goes across to the transverse, comes down, and around here you would have the rectum. Now, these kind of delicate folds in the background that are going across the bowel, that's normal. So what's abnormal is all these warty growths. These are polyps. There are innumerable polyps in this colon. Here's a particularly large one hanging off, and you can see this kind of growth of polyps. And when people have a colonoscopy and they have polyps removed, this is one of the more common types of polyps that we are removing. Usually people, of course, don't have so many, but this is someone who has a syndrome where they have numerous polyps in their colon. Here is a section of that same colon. Now you can see, let me take you through the normal structures. This pink band is the muscle, again, that squeezes the colon like a tube of toothpaste. This is that mucosa, the lining that was the same as we saw in the appendix with those little tubular glands. It's very far away here, but that is the normal lining. And what's abnormal here are these balls, these purple balls growing on top. These are all the polyps. And you can see, even though we're pretty far away, that the color is much darker than the color of anything else. And that, for a pathologist, even scanning at very high, from a far distance, we tend to look for things that are dark. Dark is usually not so good. So we tend to go look at something that's dark. And so when you go to higher power, this is the normal, those glands that are in the colon. There's a tiny bit of muscle here. That's not the big thick muscle we saw before. That's a tiny bit of muscle that separates the mucosa from the deeper vessels in the tissue. And this is one of those polyps. And you can see that it's much darker. This is normal color. You can see that it's much darker. And the glands here are darker. And the reason they're darker is that their nuclei are much larger than the normal. Let me just stay there for a minute. So this is what we call dysplastic, or something that is going on to cancer. It is not cancer yet. Now, why isn't it cancer? Because it's limited to the mucosa. It hasn't broken through this little bitty wisp of muscle yet. Once it does, that's what we would call cancer. So this is a tubular adenoma. An adenoma implies it's benign, but it is neoplastic. And if you leave it in long enough, it will eventually invade. So here's normal. Here's the adenoma, more complex this time because it's gotten worse. But you can see that it's darker. And then you can see what's invading are these glands. These glands should not be in this deeper tissue. Below this little wisp of muscle, we should just have some blood vessels and fat, and these tubular structures are invading glands. And this is colonic adenocarcinoma. This is one that has metastasized into the abdomen. So remember that in the omentum, we should only see fat, and we do see some fat. These are these pale, empty spaces. This is fatty tissue. There's a lot more collagen here. All this pink is collagen, and it's sort of too much collagen. It's because it's scarring. It's because the body doesn't like what's going on. It's reacting to it. And what's going on that the body doesn't like is these tubules. These tubules should not be here. And they look very much like the tubules that we're seeing invading in the colon. So this is metastatic colonic adenocarcinoma in the omentum, or in the peritoneum. If we're to look very closely at these tubules, it is very obvious that these cells are very ugly. And this is typical of most cancers. They look bad. So these are normal cells. This is, for instance, a lymphocyte, an immune cell. And these are just stromal cells, like collagen producing cells, and they're normal. And they give you a perspective of the size of normal cells and how dark they can get. So most normal cells are kind of pale, like that. So these are your tubule cells. These are the cancer cells. Look how big they are. Look how dark and crowded they are. And some of them, like this one and this one, are dividing. Here's another one. These are called mitotic figures. And they're a sign that this is dividing cells. And well, that's not good. Most cells in the body don't divide a lot. They're pretty quiet. So we have dark cells, large, crowded, dividing. All that is not good. And just the mere presence of these tubules in a place they shouldn't be, of course, is evidence that this is cancer. So this is fairly straightforward for pathologists, and there are no arguments about what this means. No one would have difficult time interpreting this. And the nomenclature for colonic adenocarcinomas is pretty established, and we'll see why the appendix is a little bit more problematic. So the colon is actually a place in the body where we have the most well-developed what's called adenoma to carcinoma sequence, meaning that it's very clear that we can go from normal to something that is abnormal, where we have a polyp or a growth, and then we have cancer. And it has been worked out that there are deletions, or rather mutations, of various genes, generally in a well-known sequence. And as those genes accumulate mutations, you tend to go from normal to a benign but pre-malignant polyp to cancer. And this is actually one of the places in the body where this has been most consistently studied and well worked out. Now, does this happen in the appendix? Absolutely, it happens in the appendix. And this is the appendix. And we see that this is the normal mucosa, again, with these tubular glands. And we have down here, these same tubules are invading underneath that little wispy bit of pink muscle that divides these glands from the stroma underneath it. These tubules should not be here. So this is invasive cancer in the appendix. So it certainly does happen here. This is another type of invasive cancer in the appendix. And I want to show it to you a little bit because it is a little bit different from the last tumor we looked at, and it's a particularly common type of tumor in the appendix, and it can cause pseudomyxoma. And this is what's called a mucinous adenocarcinoma in the appendix. So we can see this is the lining, again, way up there. There's a little bit of muscle that separates it. And down here, we have blood vessels. Here's some blood inside a blood vessel. These spaces are fat, and this pink is collagen. What we should not see are these lakes of blue. So that's mucus. And within it, you can see little structures. There's a C-shaped structure here, and one here, and a little bit here. So there's a whole bunch of fragments of epithelium. Here's a whole intact gland. So here we have these invading tubules or pieces of tubules, but with a lot of mucus. So this is not exactly the same as a low-grade appendiceal mucinous neoplasm, as we'll come to shortly. This is actually invasive cancer, but it is producing a lot of mucin. And so we would call that a mucinous adenocarcinoma. But that is still an invasive type of cancer. But there is an unusual type of cancer which we looked at previously and which I'm going to come back to in the appendix, which doesn't invade in the usual fashion. So here's an appendix. You can see that the lining does not have those tubules. It's kind of like this sawtooth proliferation. This tumor is a soft-tooth kind of villous proliferation. Here's the thick muscle I talked to you about that squeezes the structures to move things along. And here's the thin little muscle that just hugs the mucosa and separates it from the other structures. No epithelium should be underneath here. But you can see here, it looks like a jag, like someone took a knife and jagged it right through here. So it's not invading like we saw before. There's no little tubules in here. Instead, we have this jag through here. And that could be the way this tumor might access the abdomen, which is out here. So it's a different look that to pathologists, at least for many years, this is not what we are typically used to seeing as invasion. And so instead, we had different names for this. We'd say, oh, this is a diverticulum or a dissection or something like that, but we wouldn't call this invasion, and that caused a lot of confusion. Here's another example. So here we see the lining, again, is kind of the flat type. This is that pink thick muscle. And here, as you follow this along, we should be able to see the muscle, but here the tumor dives down into the muscle. It's doing that here as well. It's kind of a shelf, and it falls off into the stroma underneath here. So again, it's not invading in the way we saw other cancers invade with a bunch of little tubules. It's pushing its way through the wall of the appendix. And here's an example where it has burst. So again, not forming little tubules, but it is pushing its way through until finally it bursts through into the abdomen with this cloud, this volcanic cloud of mucus into the abdomen. And this is how it has now gained access to the peritoneum and can start proliferating with mucus in the peritoneum. So with that, let me give you a little bit of an historical background to some of the nomenclature issues that we had with this tumor. If you go to the middle 1800s, Rokitansky was the first pathologist who described a mucocele of the appendix. Now, in those days, I will qualify that Rokitansky was probably a surgeon pathologist, because pathology didn't really start as a separate entity until the 1900s. In those days, surgeons did their own microscopic and surgical pathology. So in 1842, Rokitansky describes an appendix that's just dilated with mucus. And it took another 40 years for Wirth to describe what we know as Pseudomyxoma peritonei, or gelatinous material in the peritoneal cavity. But he attributed it to an ovarian cyst, so that caused a lot of confusion about whether pseudomyxoma was an ovarian process rather than an appendiceal process. So it wasn't until 1901 that Frankel reports Pseudomyxoma peritonei in a male patient who obviously doesn't have ovaries, and he attributes it to a ruptured cyst of the appendix. So that's the first time that we see the connection between Pseudomyxoma peritonei and the appendix. And today we understand that most of these do come, in fact, from the appendix. But it took another 40 years for anyone to classify these mucoceles of the appendix until Woodruff and McDonald, the Mayo Clinic, they subtyped about 150 of these so-called mucoceles. And they said that most of them are benign mucoceles. They don't really qualify that any further. But they said that the ones that produce pseudomyxoma were malignant mucoceles. And you can see that's pretty vague and was not very clear beyond that. But I will tell you that the descriptions, their descriptions in their paper of a malignant mucocele were what today, or what for many years was called, didn't impress people as being very atypical. So I showed you what cancer looks like and how abnormal it looks like. These so-called malignant mucoceles didn't look as ugly as those. And over the ensuing decades, in the 50s, the 60s, and the 70s, doubts began to emerge as to whether these were all malignant. Because if you took out one of these so-called malignant mucoceles and it hadn't ruptured, it was benign. And so people felt that a benign name needed to be applied to these tumors. Now, as I told you, that polyps in the colon were already well known at this time. Adenomas were the name that were applied to these colon polyps. And they kind of looked a little bit like colon polyps, or at least the cells looked very similar. So people started to borrow the terminology from the colon, and they started to use it in the appendix. So we saw the birth of what was called a cyst adenoma. So it looks benign, but it's cystic. So they added this word cystic. Adenoma means benign glandular thing. So a mucinous cystadenoma was the term that became popularized over the ensuing decades. But the problem was, what do you call that tumor when it has spread outside of the appendix? You're calling it a benign tumor, but then when it spreads, now are you going to call it the same tumor malignant? So the terms between benign and malignant started to get very confusing. And because they were confusing, some authors started to label them things like mucinous tumor of uncertain malignant potential, because they didn't want to commit as to whether they were benign or malignant, or they said it's kind of hard to know if these are benign or malignant. At the same time, people were also studying Pseudomyxoma peritonei. And as I mentioned, this is one of those weird tumors where people who were studying Pseudomyxoma weren't necessarily looking at appendix tumors. And so a whole new nomenclature was being engendered in Pseudomyxoma peritonei that had nothing to do with the appendix tumors that produced it. And as I told you, most Pseudomyxoma, classic Pseudomyxoma, looks like this. This is in the abdomen. All these little white little spaces, these tiny little spaces are fat, but these large pools of mucin are the accumulating mucin. And when you look at the cells in Pseudomyxoma, it's remarkably bland. Here's again a normal cell. And unlike the colon cancer when it's spread, these are kind of very bland. They're kind of pale, they're not too big, and they have a lot of nice mucin. You don't see any of those mitoses. These cells aren't really dividing very rapidly. So it's very indolent looking. So again, the problem was, well, what happens if a tumor that you're calling a cyst adenoma or benign has spread to the abdomen? Well, some pathologists would look at it and say, well, it's a ruptured cyst. And they would say, well, the stuff in the abdomen, that could kind of looks benign too. I mean, we understand that it keeps growing if you let it, but it looks like benign cells that have spread into the abdomen from a benign cyst. Other pathologists would look at that and say, well, you're crazy. Whenever a tumor has spread into the abdomen, you got to call that cancer. Even if you don't think it looks like it, even if you as a pathologist think it looks kind of bland, well, so what? Other tumors are kind of bland. Not all tumors are very ugly. And so this war started to be created between those two concepts. Another concept that started, again, was from these researchers in Pseudomyxoma. Prior to 1995, there was no good term for Pseudomyxoma in the pathology world. And in fact, the word Pseudomyxoma peritonei was felt to not be a good pathology term. We wouldn't use it in pathology reports. It was felt to be a clinical term, like the clinicians, the surgeons have to tell us it looks like Pseudomyxoma. We should have different names for it based on what we're seeing under the microscope. And in 1995, gynecologic pathologists at Johns Hopkins, they were part of that ilk of people that thought a cystadenoma ruptures and spreads benign cells into the abdomen. And they called those benign cells disseminated, which of course means just spread out, peritoneal in the abdomen, adenomycinosis. Now, if you dissect out that word, adeno is the Greek word meaning gland. Mucin is mucin. And so it doesn't really imply that it's malignant. So the term disseminated peritoneal adenomycinosis kind of means like glands and mucus that have spread into the abdomen. But it sounds kind of benign. And there's nothing that sounds malignant about that. There's no word like carcinoma in that. So adenomycinosis implies that benign cells are spreading in the abdomen from a benign tumor that is perforated. Now, this term was adopted by pathologists, I think because people were desperate for some name to give Pseudomyxoma, and it was at least consistent. Actually, surgeons kind of liked it because they knew exactly what we were talking about. Some pathologists, however, just dug in their heels and refused to call anything disseminated peritoneal adenomycinosis on principle, because they kept saying it can't be benign. It's got to be a malignant condition. When things spread outside of the organ from which it was born, that's the definition of cancer. So they kept wanting to call it peritoneal carcinomatosis. So you can imagine the quandary that this started creating. If you called something DPAM, you could say, well, the tumor that produced it was a ruptured adenoma. If you were calling something peritoneal carcinoma, well, then the tumor that produced it has to be a cancer. And between all these different varieties, it became very confusing. And you could have your surgery at one hospital and they would tell you that you had a ruptured adenoma with disseminated peritoneal adenomycinosis. And you'd go to another hospital, and the pathologist there would look at your slides, and they would say, you had peritoneal carcinomatosis. And then you were like, well, do I have cancer or don't I have cancer? That seems to be a critical point. We were all talking about the same thing, but we weren't all using the same language. And every institution had their ways of practicing, their surgeons who were used to their terminology. In 2003, that's when I kind of entered the scene. I was young, probably not too sophisticated about this topic, and I had a bunch of cases. And the way this came about, actually, was I had a case. I was very young, and it was very complicated. As you can see, I probably have confused you entirely by this discussion. And I had a case, and I didn't exactly know what to call it. And I took it to one of my mentors. And I showed her the case, and she gave me the name to call it. I don't even remember what we decided to call it anymore. And I said, you know, I should try to do some kind of project on this or study this in some way so that I would understand it better. And she goes, oh, here you go. And she hands me a collection of about 100 cases that she'd been collecting for probably 10 years. And she just couldn't organize it and put it together. And it probably took me about 3 years to finally organize this. I was helped, this is her, Fiona Graham Cook was my mentor. Robert Young was a gynecologic pathologist who had a lot of interest in this from the gynecologic point of view. And Rhonda Yantis is a well-known gastrointestinal pathologist who was training with me and is very bright and very, also very interested in this topic. And we finally published this. And what we decided was that we have to find one name that everyone can agree that if the tumor is limited to the appendix or it is spread to the abdomen, we can use the same name for this tumor. And we understood that there was this enormous controversy if you wanted to call it a cyst adenoma or benign, a lot of people were not going to accept that. And if you wanted to call it carcinoma, there were other people who weren't going to accept that either, and we would never get people to agree on one term. So we copped out, actually, and we called it a low-grade appendiceal mucinous neoplasm, a very generic term. Low-grade just means kind of indolent. Appendiceal obviously means it comes from the appendix. Mucin just has a lot of mucin. And neoplasm is just a general term for a tumor. Doesn't mean benign, doesn't mean malignant. And so it was kind of a cop-out term, but it caught on because people could finally use one name for this tumor, regardless of whether it was just in the appendix or whether it had spread to the ovary or it spread to the peritoneum. We could all say, oh, this is a low-grade appendiceal mucinous neoplasm. And now we could begin to study it and its behavior and its genetics without getting confused by, well, what are you calling cancer? What am I calling benign? And so we finally had a name that we could call this tumor. Now, until 2010, there you could see that there were a lot of different names for these tumors. This is just an example of the nosological confusion. There were other people who had published in this area, and I didn't go over their papers, but you could see that if a tumor was confined to the appendix, we would call it a lamin. Other people would call it a mucinous tumor of uncertain malignant potential. Other people would call it benign. And so various names are being used for these tumors. And until 2010, when the World Health Organization adopted low-grade appendiceal mucinous neoplasm, and you would have hoped that that would have created some uniformity. But while the WHO sounds like it has a lot of cachet, sometimes people still insist on using their own terminology. Pseudomyxoma peritonei had its own terminology. So again, strangely, completely divorced from the appendix tumors, there were those people who for pseudomyxoma would use DPAM. Other people refused to use that terminology because they insisted it had to be called cancer or carcinoma. And then we would just kind of use a descriptor, to be honest. We'd used neither of those terms, and we made up our own language. So everyone had a lot of different languages. So sometime around 2013, there's a group that many of you may know. It's called the Peritoneal Surface Oncology Group International. And they started sending out emails asking people who are interested in this from the point of view of pathology, surgery, even social workers, people who dealt with appendiceal neoplasms and pseudomyxoma peritonei, if they would agree to try to arrive at consensus terminology for appendiceal tumors and for pseudomyxoma peritonei. And they did what is known as a modified Delphi process. So what they would do is they'd send you a survey and they'd say, well, what would you call this? And what would you call that? And you would answer a few questions and you'd send it back to them. And they would collate those answers and then they would show you the answers. And what was evident, of course, is that you would realize that sometimes you were in a minority. And that helped you to realize that maybe you should switch to what the majority was using. And maybe you were an outlier. And once you saw the results of the survey, once you would see the results of the survey, they would do a new round of surveys. And they did this a few times, hoping that by showing you that you were an outlier, you would conform to the group. We had two meetings that were notable. And the first one was notable. It was in 2013 in Basingstoke. And what was most notable about this was that we all, despite the fact that the World Health Organization had adopted low-grade appendiceal mucinous neoplasm in 2010, 3 years later, everyone was still using different terminology. And these are the number of responses on the left. So for instance, you can see that 6 people, if you ask them, well, what would you call a tumor if it was just in the appendix? And they didn't know. What would you say if it had infiltrative invasion? Or what would you say if it was pushing? And you could see that different people had different responses. Some people would call things lamin. Some people were still using uncertain malignant potential. Some people were still using adenocarcinoma for something other people would call lamin. Some people had even invented something called a lamin 1 and a lamin 2. So there were all different types of names being applied to these appendix tumors. Over the years, there has been more and more uniformity. That group, the PSOGI, has issued white papers. And I think what's also been helpful in this regard is that that process really connected several of us who have been publishing in that area. Norman Carr, Rita Shpai, myself, Rhonda Yantis. We all got to know each other. And I think between that process and getting to know each other, we've been able to arrive at more uniform terminology. And last year, the World Health Organization published a new iteration of these tumors, and this was now published by those same people who did the survey. And so there's much more consistency in the terminology. So now, appendiceal mucinous neoplasms that have this curious way of pushing their way through the appendix are no longer called cancers. They are called low-grade appendiceal mucinous neoplasms. We do recognize that this is ultimately, in a very broad way, a low-grade type of malignancy, but we don't use the term carcinoma or cancer to describe them. But sometimes you have these tumors that are pushing through, and I'm going to show you that in a minute, and you look at the cells and they are nasty. And that was, for many years, also a little bit problematic. But now we've decided if there isn't these tubules growing into the tissue, like I showed you with typical cancer, we're going to call those mucinous neoplasms. And most of them are low grade, but sometimes they can also have nasty cells and be high grade. So this now is a low grade appendiceal mucinous neoplasm. So you can see that this is that little muscle and there's it's kind of growing and it doesn't look terrible. Here's an example where it does look terrible. Those cells look awful. They're much bigger, they're more jumbled, they're darker. These little bars here are cells that are dividing rapidly. So it's dividing rapidly. So we would call this a high grade appendiceal mucinous neoplasm. So we still don't call this cancer because it isn't invading the way cancers tend to invade. So to call something a cancer, it has to be invading the way I showed you initially. So there are typical cancers, there's ones that have a lot of mucin, and there are ones that have a lot of signet ring cells, and I'll come to that in a moment. So most tumors that produce pseudomyxoma are low-grade appendiceal mucinous neoplasms. High-grade ones are rare, and then there are tumors that invade, and that's the types of cancers that can also be present in the appendix. Returning to Pseudomyxoma peritonei, the same authors finished writing a chapter on Pseudomyxoma peritonei, and that's due out probably in a month or two. And I want to go through where we are with that now that it's been pretty much established to be more uniform as well. This is classic Pseudomyxoma peritonei, a photograph I showed you before. What's classic about it? There's a little bit of fat here and some pink collagen, and there's abundant mucin pools. But you can see from this magnification, we're really high up, it's kind of hard to see that there's any of those cells floating in it. So it's certainly not a lot of cells, and we would have to go hunting to find cells. And that's typical of classic Pseudomyxoma. It's got a lot of mucin and some fibrosis and scarring, but not a lot of cells producing the mucus. When we go look for those cells, we can find them, and here they are. So they're rare, and they don't look too bad, not too abnormal, a little bit dark, lots of mucin. These bubbles on these cells are mucus, and you can see that they're producing a lot of this mucus. This is classic Pseudomyxoma peritonei. Here's a picture I showed you earlier. Again, if you look very high magnification, the cells don't look too bad. They're a little bit enlarged, not terrible. There's not a lot of cells dividing, and they have a lot of this mucus. Here's a little bit of mucus here and here. So they're producing this mucus to dump into the abdomen. Here's a different case. And you can see there's a lot of mucin pools, those gray mucin pools. But in this example, it's easy to see that there's a lot of little buds of epithelial cells, these little clusters, some of them little bars, some of them little aggregates. So even from this high magnification, even from like 10,000 feet, it's pretty clear that this is different. This has a lot of cells in it. When you go look at higher magnification, you also can see that those cells are more abnormal. There's ones that are probably dividing. They're much larger. They're not forming a gentle single strip. They're all climbing on top of each other, forming this kind of interlacing mass, much larger cells. So this is more high-grade Pseudomyxoma. Years ago, there were researchers. This is the one who introduced this term, disseminated peritoneal adenomucinosis. So I'm not going to go back to that, but what I want to point out is that this is classic Pseudomyxoma. This is what I just showed you, more high-grade Pseudomyxomas. And this is the survival. So people with classic low-grade Pseudomyxoma do better than people with high-grade disease. These have different terms, but let me just simplify this by saying that both of these groups were high-grade groups, and when they published another paper 6 years after the first, these groups merged. So this group is essentially can be viewed as one group with high-grade disease, another group with classic low-grade disease that they called DPAM. This was borne out in several studies. This is another group that looked at Pseudomyxoma peritonei, and they found the same thing. Patients with low-grade Pseudomyxoma survive longer than patients with high-grade Pseudomyxoma. But these folks used different terms. They didn't like DPAM terms. They used different terms, but ultimately the same idea, low-grade versus high-grade Pseudomyxoma. So for some time, we knew that low and high grade, 2 grades, they did differently. In around 2013, there was increased interest in signet ring cells. What are signet ring cells? I'm going to show you another picture of them, but this is Pseudomyxoma with signet ring cells. This looks different from what we've seen before. There's smaller mucin pools. There's this gray mucin here. There's some fibrosis or collagen, all this pink stuff. And the tumor cells are these guys, these little cells, these cluster of cells floating in the mucus. And you can see if you look at some of them, they are individual, a single cell here, here. Some of them are in small groupings, but there are a lot that are just one single tumor cell. This is a signet ring. This is obviously what someone would use in days of yore to put their imprimatur in wax, like a seal of wax or something like that. And so you can see this is why they're called signet ring cells. Here's a good example. This is mucus within the cell. It's actually a single mucus cell. And this is its nucleus that's pressed to the edge. And so the cell looks kind of like a ring on its side. Here's another. So all these are signet cells. Here's another example. Here's several. It's a little bit lower power, but you can see there's all these single cells in here. And so these are signet ring cells. And what was found, this is the first study that showed this, is that if you looked at Pseudomyxoma peritonei with signet ring cells, which they called grade 3, those people did even worse than people who just had high grade. So they found that classic Pseudomyxoma, low grade, did best. People with what we were calling high grade did not as good, but people with signet ring cells did worse than the other groups. Why would that be the case? Well, I'm going to show you, this is classic Pseudomyxoma on the top. This is signet ring cells here on the bottom. And I'm going to compare that to these two protests that were occurring in France. On the top, you can see that the protesters are linked arm in arm, just like these cells. They're all joined in this strip. Now imagine if these guys had to move. How fast could they move being linked arm in arm? Not so fast. It's just going to slow them down if they have to stay linked arm in arm when they move. Here are signet ring cells, and I mentioned that those are individual, single cells. And here's that same protest, but all the protesters are not linked arm in arm. They are traveling singly by themselves. If these guys had to move, they're going to move a lot faster, and they can get into smaller cracks and crevices than a group like this could. And so that's the same idea. Signet ring cells can infiltrate tissue faster, and they are harder to control because they are single cells moving around by themselves as opposed to being tightly linked arm in arm with each other. And that's what makes potentially signet ring cells a little bit more ominous. So here they are side by side, Pseudomyxoma peritonei, grade 1 or low grade. This is classic Pseudomyxoma peritonei. This is an example of grade 2 now, which we used to call high grade, which you can see is much more cellular, has lots of cellular units in kind of funny configurations, not just simple little strips like this. And this is grade 3 with a lot of single signet ring cells. As we come up to the publication of this chapter in the WHO, we as the authors had to come up with a name for Pseudomyxoma peritonei. And I mentioned to you that DPAM is increasingly being frowned upon as not really reflective of the pathology. And it's certainly a term that while many people used, not everybody could get behind. The white paper that the PSOGI published some years ago, they advocated that we should call all cases of Pseudomyxoma mucinous carcinoma peritonei, and they acknowledged that some people might use DPAM. However, when I started to write this chapter for Pseudomyxoma, I actually, being part of PSOGI, I said, well, we don't use mucinous carcinoma peritonei in our hospital. Our surgeons don't like that terminology unless it's very high grade. For classic Pseudomyxoma, they don't want it labeled as carcinoma. So we never use that terminology. And we don't use DPAM either. But when I was writing the chapter, I said, well, I guess maybe it's time that I, use uniform terminology, and maybe I need to, use mucinous carcinoma peritonei. And so I wrote it up that way, and I gave it to Norman Carr and Rita Shpai, other authors that have been part of this process. And Rita Shpai, it turns out, also, it works at a hospital where they do not use mucinous carcinoma peritonei. And he said, if we use that terminology, it will not be consistently used. Many places will not use that terminology for classic Pseudomyxoma peritonei. And we hemmed and hawed, well, then what are we going to call it? And it was actually Rita Shpai, I think, who intelligently suggested, let's just call it Pseudomyxoma. And years ago, I told you that no one liked Pseudomyxoma peritonei as a pathologic term. That was reserved for the surgeons to use when they saw a mucin in the abdomen. But we finally decided, we all know what we're talking about. When I say pseudomyxoma, grade 1, you know what I'm talking about. And when I say pseudomyxoma grade 3 with signet ring cells, you know what I'm talking about. So in fact, we adopted Pseudomyxoma peritonei as the name for these tumors, these mucinous tumors in the abdomen. And we said that mucinous carcinoma peritonei was acceptable if that's what you use, but if not, then the name we were advocating is Pseudomyxoma peritonei. So this is what it will look like. We will now call those tumors in the abdomen on the pathology report Pseudomyxoma peritonei, grade 1, grade 2, or grade 3. And so that term has come full circle. So I'm going to conclude by saying that in the 1950s, since the 1950s, there's been increasing agreement on terminology of appendiceal tumors. We went from not really even being sure where pseudomyxoma came from, controversies that it might come from the ovary, to understanding that most tumors that produce it are low-grade appendiceal mucinous neoplasms. Sometimes they're mucinous adenocarcinomas where they actually are invasive, or now we're seeing increasingly high-grade appendiceal mucinous neoplasms. I think that now that we know that, we can also say that we could say low-grade appendiceal mucinous neoplasms produce pseudomyxoma peritonei, and that can be more consistent in the pathology reports as well. And I think using the same language has facilitated communication with surgeons, with patients, and with each other. And I think very importantly, it has really helped in the research in this area. When you go and look back on data from prior to 2010, people would report genetic findings in carcinomas of the appendix, but you never knew what they were talking about. You didn't know if that meant it was a low-grade appendiceal mucinous neoplasm, or was it an invasive cancer? You just really never knew what they were talking about. And at least now, when someone reports genetic mutations in a tumor, we know what they're talking about. And so I think these efforts have really paid off in our study of these diseases, and hopefully in achieving consistency across different specialties. And with that, I might have confused you. I know it's such a confusing topic, but I will absolutely take any questions and try to explain anything better if I didn't do a good job the first time.
Dr. Misdraji, that was fantastic. Thank you very much.
Yeah.
And I'm sure I'm not the only one who wants to applaud the detail of your presentation and the learning that we've gained today. That's fantastic. So I want to start by reminding the group, if you have questions, please email them to zoom@pmppals.net. And Adele is aggregating those questions, and she'll be asking those of Dr. Misdraji. I have a couple questions that I wanted to ask myself, Dr. Misdraji. I often hear the term differentiated, moderately differentiated, what does that term mean, and how does that apply to what you've just shown us?
The term differentiated means, to some extent, and I'll qualify this in a minute, how well is the tumor trying to look like the organ from which it came? So for instance, let me take a different organ for a minute, the liver. If you were to look at a liver under the microscope and then have liver cancer, you would ask yourself as a pathologist, how much does this look like normal liver? If it looks very much like normal liver, actually can be very difficult to even tell it's cancer. It looks so much like normal. We'd say that tumor is well differentiated. It looks like liver. If it's poorly differentiated, it's making no effort at all to look like liver. And it just starts to look like cancer of any kind. And it gets really hard to tell that it actually came from the liver at all. It could have come from anywhere. And moderately differentiated is somewhere in between. Now, that being said, there are rules for tumors, like, how do we define well, moderate, poor? There are rules for most tumors on how we define them, but most people go moderate, somewhere in between. That tends to be where most tumors land. Even though we have rules, people tend to use their experience. Just like, you have experience with children, and you can say who's well-behaved and who's poorly behaved. And there might be rules, but you'd be like, rules, schmools. I know a kid who's well-behaved when I see one. And so that's the idea. It's tumors that are bland, tend to be well differentiated. They are looking like the tumor from whence it came. So in appendix, it's how much those glandular cells are trying to look like glands and benign glands. And the more they're trying to do that, the more it's well differentiated or low grade.
Very good. Excellent. Thank you. That helps me understand for sure. And then another question that I had, and maybe this is perhaps for both you and Dr. Lambert, but do you then get samples of biopsies post IV chemo where you're seeing these cancerous, the tumors at all, like any of the cells, where they're dying? Are you seeing that in some of the pathology as well?
When we don't get as many tumors that have been treated when they're low grade. So when people have low grade tumors, they tend to go to surgery rather than getting chemotherapy. But occasionally people have higher grade or signet ring cell tumors in the abdomen. And so let me just limit my, my comment to what you're dealing with pseudomyxoma, where sometimes what we can see, it's not so much that we see the cells in the process of dying, but when tumors are killed off, they leave behind mucin pools. And that will take time to resorb. The body will slowly resorb that over time, but not probably in time for someone's surgery. So if they had chemotherapy and then within a couple of weeks they had their surgery, then there's still probably going to be mucin pools. And what we do as pathologists when we know someone's been treated is that we try to assess how much of the tumor remains. So we don't necessarily see dead tumor, but we see empty, lots of mucin pools where there might have been tumor. And we will give the surgeon a sense of, is there a lot of tumor left, not so much, or very little viable tumor? Because the more the tumor's been killed off, the less viable tumor we can find. And that is a good prognostic finding. The better that chemotherapy in any tumor, the better that chemotherapy killed off the tumor prior to surgery, and the less viable tumor we find on pathology, the better the prognosis.
Fantastic. Very, very interesting. And to learn that the chemotherapy is making it through those mucin pools, that's exciting stuff. Dr. Lambert, so we recently had Professor David Morris on to talk about the BROMAC trial, which is a combination of bromelain and acetylcysteine. And so I learned during that presentation that one of the great benefits of that chemotherapeutic approach intra-abdominally is that it dissolves the mucin. And yeah, so one of the questions I had, I know that mitomycin is the drug that we use during HIPEC. Does the heat and the mitomycin itself tend to help with dissolving the mucin? And so it's just interesting how the BROMAC is working and, you know, relieving the mucin pressure. And now as I see the signet ring cells, I'm understanding in a different way that, oh, wow, the mucin really is problematic here. But so do we see some of that type of dissolving of the mucin with mitomycin C, or is it still tricky to work with?
Yeah, so we don't usually see the dissolving because when we do the HIPEC with mitomycin C, it's usually after we've removed all the tumor and the mucin. So we're really just treating the belly cavity at that point, right? So we're not putting the mitomycin C and the hyperthermia in while there's mucin in the abdomen and then opening it up and seeing that. It's an interesting, I mean, that would be an interesting thing to look at. We could certainly do that outside of the person, right? Once the mucin is removed, put that aside for like a study and heat it and treat it with mitomycin and see if it would have a similar effect as the bromelain. But I suspect it's probably more of a chemical process that the bromelain and NAC are just sort of breaking down the proteins that are in that mucin and making it more liquid so that it can be drained off more easily. So, you know, that mucin, the way I kind of describe it is, it's kind of like, it looks like apple jelly when you see it. I mean, you saw those pictures that Dr. Misdraji showed, and it's very thick. And if you try to just drain it with a needle or a small tube, it won't come out. So That's the purpose behind the bromelain, is to break it down so it gets really watery and thin, and then you can just drain it out and get it removed that way. Because you're right, Chris, over time, as it builds up, it becomes a problem. It prevents the intestines from functioning normally, and that's obviously a concern over time. Dr. Misdraji, I just want to say this is the second time I've heard you give this talk. It is phenomenal. It is, for those of you in the audience who have never heard other pathology talks before, this is really the best pathology talk I've ever heard. It's just the language is beautiful, the pictures, the descriptions. This is such a complex topic, and to review the history so eloquently as well. Thank you very much. Thank you for all your efforts in this. I am so grateful that we're back to Pseudomyxoma Peritonei.
Oh, God. Thank you, Laura.
Well, and I'll add, I'm texting with other people who are able to communicate with me through different modes, and there's more than one fan here, Dr. Misdraji, for sure, especially in the pharmaceutical world. So it's exciting to have you here.
Yeah, we've had a few questions come in. So one question, can the pathology change from grade 1 to grade 2 to grade 3 over time?
It has been reported. It's unusual, I think, for it to go the full length of that. But it has been reported as people have serial surgeries that you can see higher grade over time. It's not common, but it does occur. Sometimes that can be different areas. Sometimes it can be the effects of treatment. Sometimes it can be because tumors, as they grow, can acquire new mutations. And so those new mutations can make it more aggressive. So yes, it can happen, but it's not common.
Thank you. I think we talked a little bit on the difference between poorly to moderately differentiated, and then the side question is, prognosis and how do treatment options vary?
Laura, you want to handle that one? Yeah, so this is a really important question, and it's also really important to have, if you're newly diagnosed with an appendiceal tumor or cancer, to have somebody like Dr. Misdraji or another pathologist who is comfortable with looking at these tumors to classify them, because it does impact what we recommend. And so like Dr. Misdraji said, for the low-grade mucinous neoplasms and even the low-grade adenocarcinomas of the appendix, we will often recommend surgery up front with the heated chemotherapy if that's indicated, if there's pseudomyxoma present. Once you hit the moderately differentiated, let me start. Once you get to the other end of the spectrum, like what Dr. Misdraji was talking about, the high-grade tumors, the poorly differentiated, the signet ring cells, most of us are really recommending systemic chemotherapy up front to try to shrink the tumor, see what kind of response it has to the chemotherapy, and optimize our chances at the time of surgery to remove all the cancer and do the heated chemotherapy and have it be effective. In the middle is the moderately differentiated, and that gets where it gets a little more gray and where we really individualize it to the person. So if somebody has a moderately differentiated adenocarcinoma, very low volume of pseudomyxoma or tumor implants in the abdomen, we may recommend surgery up front. If it looks like it's going to be, there's a little bit more cancer that's already spread through the abdomen, and we want to try to use some chemotherapy to shrink that, to again test the biology and help us get it all out at the time of surgery, we may go that way. So that's sort of how I approach it. Low grade, either neoplasm or adenocarcinoma surgery up front, high grade or signet ring cell chemotherapy up front, moderately differentiated, picking surgery versus systemic chemotherapy based on the individual circumstances of the person.
And where would goblet cell fall in?
Right, so that's a whole nother topic, but clinically speaking, and with from a surgeon's perspective, we would put it in that moderately differentiated. It's probably between moderately differentiated and the poorly differentiated, so it's in that next level up. Oftentimes, and Dr. Misdraji, please comment too, a lot of times we will see when he gets the tumor, he'll look under the microscope and the goblet cell is this combination of something that we call a neuroendocrine tumor. It has some features of that, but also the adenocarcinoma, the gland-forming cancer. And those will, that part will more often be a higher grade tumor. So again, it's in that gray zone, and we will often do chemotherapy first, and for the same reasons for the higher grade. But Joe, do you have any other comments on that?
Well, only, I guess, if we're talking about pseudomyxoma peritonei in particular. So, because I'm happy to talk about the goblet cell tumors in a complete different lecture, because it's also something that has been unfortunately plagued by bad terminology or different terminology and lots of proposals for different terminology. So it is an enigmatic tumor of the appendix, which I did not show you, which, as Dr. Lambert said, does have some features of a neuroendocrine tumor, but when it goes bad, it tends to go toward more gland producing and even start to resemble signet ring cell tumors. And so when they metastasize to the abdomen, they will be something on the order, if we're talking about pseudomyxoma, they're going to be similar to either the grade 2 or even a signet ring cell looking type of tumor when they go to the abdomen.
Okay, let's see, another question. So clearly the question is, how important is an accurate pathological assessment? And I think, you know, your talk has demonstrated that it is, and in a correct classification. And so would a genomic test of the pathology, you know, help determine whether or not chemo would work?
Not really. And again, Laura, you can tell me your thoughts on this, but most, at least it depends. It depends on the grade. Most low-grade tumors have very few mutations. They, like 90% have what's called a KRAS mutation, about 75% or 50% might have something called a GNAS mutations. They don't tend to have other actionable mutations. As you get high-grade tumors, sometimes there is a role for genetic testing of tumors that have spread, because those high-grade tumors tend to have a higher mutation burden. There are more mutations in the genome in those high-grade tumors. And then perhaps there's more a role for more personalized medicine kind of thing. Usually there are standard things like mitomycin that you start off with, and if those fail, then you do, I think, take the approach of molecular testing to see if there's something that is targetable in that tumor, but they tend to not be first-line choices. They tend to be more salvage choices or second-line, third-line choices. Dr. Lambert, would you add to that? Or is that?
No, all I would say is, you know, that really is the holy grail of, you know, cancer therapy. Is we would love to be able to take these tumors and just run these genetic tests and have the computer tell us, you know, you need to give this person this chemotherapy and it's going to kill all the cancer. That's what we're really hoping for. Unfortunately, right now we run all these tests and we get, you know, all these mutations that are occurring in the tumor cells, but we just don't have the agents to target those mutations or to know if that's going to be helpful. So, you know, we're still at a stage where we're treating everybody with the same approach, regardless of what their tumor mutation looks like, until, like Dr. Misdraji said, you know, those therapies seem to stop working, and now we're looking for, is there something we can target, that we have an agent to target?
So one comment that I want to make, right? I think this journey for us as patients and caregivers can often be about communication. And I think we've really seen demonstrated today that, like, even our experts are having trouble, you know, dealing with the complexity of this disease and the different diagnoses and the different treatment paths. So it's a complex disease. We're huge advocates of just getting patients to our specialists. And I mean, we love them, but we really believe it's that important. While we do have very talented surgeons and surgical oncologists, the knowledge of the disease and how to treat it, it's really essential. And I think it goes back to the basics. Us being willing to ask questions and be brave and become educated, I think is going to help us have better outcomes. So communication is key, that's for sure.
And I would really encourage, you know, you guys know this, everybody here, you know, if you or somebody you know, or, you know, somebody connects with you guys and they've just gotten a diagnosis of this, really, really encourage them to have their pathology reviewed by somebody like Dr. Misdraji at a program where there's a HIPEC program where they're probably seeing lots of appendiceal tumors, because it really, really does matter. It really matters greatly. And too often we see, from the surgical side, we see somebody who was told one thing and they went off on a treatment plan that, had we known, we would have really recommended something different. So.
Yeah, I kind of want to add something to that. One of the it's a very strange paradox, but I will say that one of the downsides to having widespread recognition of any name is that people apply it more often. So if you have a hammer, everything's a nail. And, for instance, high-grade appendiceal mucinous neoplasm has only been introduced in a year. Suddenly people see it all the time and you're like, no, that's not it. No, that's not. So I think the people who are, where someone asks, is it important to have a good pathologic diagnosis? Where I think it becomes very critical is that sometimes, low-grade appendiceal mucinous neoplasm has become a very popular term, and pathologists now seeing a lot of different things are struggling with that, with calling a lot of things lamin that sometimes people have reviewed, and I'm sure Dr. Lambert has seen this, where an expert pathologist says, this isn't a tumor at all. This is just a post-inflammatory appendix.
Yeah.
And the person, was all scheduled to have something big happen. And the pathologist said at an institution where they see a lot of this, says, this isn't neoplastic at all. And that's the downside, perhaps, of everyone, of this kind of uniform language and the emphasis on it. There's a good part, but the downside is that people who don't do it a lot start to see it a lot or think they're seeing it, and they're not always right. So it's important to have pathology review it.
Well-intentioned, but and being super cautious. I think that kind of drives it too. They don't want to, the pathologists don't want to miss something, and they certainly don't want to undercall something because they're worried that people won't get the appropriate treatment. But.
Right, exactly.
Yeah, another question or topic to address, many patients sometimes report that people question whether or not this is really cancer. And so from an emotional perspective, they're made to feel it's not as serious. And so can either of you talk a little bit about that?
Yeah, so I have this conversation almost every clinic, unfortunately, and I agree. It is really difficult to understand, and particularly, people who get the diagnosis of a lamin are like, so what do I tell my family? Is this cancer or not? And, and I try to be as honest and clear about it as I can. And just like Dr. Misdraji said, I say, technically, this is not a cancer because it does not have any ability to invade into other tissue, into the lymph nodes or into the bloodstream and spread to other parts of the body. And just like he said in his talk, that's what defines a cancer. When the pathologists look at it under the microscope, they don't see any of those features that he was talking about, it breaking through that thin little muscle layer or anything like that. And I say, and that's the good news. Now I say, but it's not normal. It is a tumor, it's a growth. Not every tumor is a cancer. And I describe benign fatty tumors that people have called lipomas. Those are not cancers. They're never going to spread anywhere. But because the appendix is so thin walled, and just like he showed you in the slides, it's so easy for these tumors to break through that wall, and that these cells get out, and these cells just make mucin. It's more of a mechanical problem, really, than it is about an aggressive cancer that has broken through the wall. And the problem is that these cells get out in the belly cavity and they're programmed just to make mucin, and they just keep doing that, right? And over time, and when I say time, I mean by years, that mucin can build up, and that can be a problem. So it's not malignant, but it's also not benign in that it's not potentially harmful or life-threatening. And so we have to do something about it. And I say, even though it's not cancer, the best treatment that we have for this is to do this heated chemotherapy washing to kill the cells that make the mucin, because they're not normal cells, even though they're not cancer cells. So that's how I kind of explain it.
Yeah, and I think this is one of those diseases that sometimes challenges our notions of what is benign and malignant, where as people are communicating, we want things to fit into boxes so that we can communicate. But there are other examples as well of tumors in the body that are aggressive in their own novel ways. And so yes, it doesn't necessarily metastasize like your typical cancers, you know, but it does spread. So it does become like what you would say is a locally aggressive tumor sometimes. So I think trying to think things as a binary, is it benign, is it malignant, will get you into this quandary of what exactly is it. But if you think tumors have a spectrum of behavior, this is on the somewhere on that spectrum.
So whether low grade or high grade, the importance of a qualified pathologist looking at it, a qualified surgeon is important, because you know it's a serious thing, and so it's nothing to be dismissed, and you know, making sure the diagnosis is correct is very, very important. Now, will chemo work for low grade that has recurred after 2 HIPECs? And could a patient in that scenario have a 3rd HIPEC?
So the answer is it depends. So definitely, you know, yes, people can have a 3rd HIPEC. Again, it depends on the individual circumstances, you know, about, you know, how recovery from the previous HIPECs, what was operated on, you know, the condition of the abdomen as you try to get back in. It also depends on how the timing of when the tumor came back. You know, if it was right after the last HIPEC, you know, within 6 months, probably most surgeons wouldn't be too excited about doing another HIPEC if it came back that quickly. And also that would probably tell us a little bit something about the biology, that maybe this really isn't a low-grade tumor, even though it looks like it under the microscope. It's behaving in a high-grade fashion, so we might consider doing chemotherapy. So you really have to kind of take all those things into consideration. And if you get another biopsy somehow, and you know the pathologist looks at it under the microscope and sees like, well, yeah, looks like maybe these cells have, you know, kind of transformed and they're a higher grade, that might, you know, also compel the surgeon or the medical oncologist to think about chemotherapy instead of jumping right back into another surgery. So it'd be very individualized. You know, if it was clearly a low grade thing that came back 5 years after the 2nd HIPEC and it was relatively low volume, it got caught early, person did really well after the 2 previous HIPECs, then probably you'd go right to HIPEC at that point. So again, once you get past sort of that first the diagnosis and then the, you know, the HIPEC or the chemotherapy in the HIPEC, once you get to that next, if it comes back, it gets very individualized about how we decide to treat it.
I have a question from another channel, Adele. And so the question is, are there CT scan results that would not indicate further surgery or HIPEC after an initial debulking? So for example, if the appendiceal tumor is low grade and is attached to the ovaries, which have been removed, omentum, which has been removed, and appendix, which has been removed. So are there CT scans that would indicate further HIPEC is not necessary?
So is the CT scan is not showing any tumor? I'm sorry, can you say it again, Chris?
Yeah, sure. So I think if we have appendiceal tumor that's low grade and it attached to ovaries, omentum, and appendix, and those have all been removed. Yeah. So CT scan is going to be a diagnostic tool moving forward. And I think, you know, certainly you're going to see if there's regrowth, and if there's regrowth, then as you just discussed just a moment ago, right, then it's an individualized approach and consideration as to whether additional HIPEC or surgery.
Yeah, if it's a low-grade mucinous neoplasm that was diagnosed and somebody had surgery and the surgeon at the time, you know, found things maybe more than he or she was expecting and removed those and got a good complete cytoreduction, and then found out what the diagnosis was, and we often see that. Yeah, I would just wait at that point and, you know, see, you know, provided that the CT scan or imaging from before the surgery didn't show something that wasn't picked up either at the time of surgery or prior to surgery. And if that CT scan looked good, I would probably just follow, you know, the CT scans at that point, keeping a close eye on things, check tumor markers. And if something comes back at that point, plan to go and do the surgery and the heated chemotherapy. The nice thing about low grades is that they do tend to show up really well on imaging studies, on CT scan and MRI. Unlike the higher grade tumors, particularly like the signet ring cells, where they tend to grow like little plaques or little polka dots, and it's so hard to see them on CT scan. You know, you don't see them until you either put a camera in or you're right there looking at them. That can be that's really challenging on CT scan. But usually the low grade, because they're going to develop that mucin, they're going to develop tumor nodules that you can really see pretty early on CT scan. So that's, at least based on the information that I have, that sounds like what I would recommend in that circumstance.
Good,
Yeah.
Great, thank you. Adele, do you see further questions?
Yeah, no, just maybe another general question. Do you think there needs to be continued education in maybe the medical oncology community, you know, gynecological, surgical oncologists, to not miss PMP? Or have we come further now where people not in the PMP world recognize it a little more easily?
I guess I'll start, and Laura, you can pick up what I don't cover. I would say that there actually is a decent amount of continuing education. Of course, all physicians do that quite a bit. And the appendix, I think, because of these movements, these papers that have been written, the changes that have happened, I actually think it's becoming a bit of a hot topic. And so I think that a lot more people are aware of it. Again, the good part is that people are more aware, and then the downside might be that well-meaning people are stumbling through it. But there is actually, I think, a lot of interest in this. There's been a lot more research in it. So I actually do think there's a lot of education. I think there's there's increasingly few people who have not heard of pseudomyxoma, are not familiar with it. They may not have dealt with it themselves, and then they would have to refer the patient to someone or a center or a surgeon who deals with it. But I think it's increasingly common for people to have heard of it and to at least recognize the circumstances. Dr. Lambert, maybe you can add to that.
I think so too. I think we are starting to see better recognition of the disease, of the potential treatments that people need to get to a specialist. I think some of that is still, though, largely being driven by the person who's got the diagnosis as well, because, you know, invariably, most of the time when somebody comes to see me, they've been online, they're educated, they've got great questions. They've probably been the one that initiated the referral to me or to a HIPEC center. We do still need to do some work with the gynecologic oncologists, you know, because it can be hard to separate out ovarian cancer and appendiceal cancer before you get to the operating room. But what we would love to see, because the two tumors are very, very different, their treatments are very different, is that, you know, if at the time of surgery, the GYN oncologist kind of recognizes that, well, this doesn't look like a garden variety ovarian cancer, maybe I should stop and just get some biopsies and see what comes of that. That's kind of something where I think we need to work on education around that better, because it matters. It actually has an impact. And then the other place I think is, you know, well-meaning general surgeons who are very good general surgeons, but don't know that, you know, you can, you know, for a low-grade mucinous neoplasm, if you've got a normal base of the appendix, which most of the time you do, you just need to take out the appendix, you know, and if it hasn't spread, then that's often a cure for the person. You don't need to take out the right colon. There's no chance that the lymph nodes are going to be positive. And so I think some education around that as well will be helpful. But I do think it's getting better, no question. You know, the concept of appendiceal cancer tumors and the concept of pseudomyxoma, and that there is actually treatment for it, is definitely people are becoming more aware of it, no question.
Thank you.
Great.
Yeah, and Chris Charmaine has some comments if we have time.
Oh. You're still muted, Charmaine. I've got you.
Okay.
There you go.
I know the time is short, and I really want to thank both of the doctors. Y'all are so fantastic. It's just great. I just wanted to make a comment as someone who was diagnosed in 1997. This has been very educational, because for many years I felt like a very stupid person because I could not follow all of this terminology. I really had so much trouble. You know, I'd see things in my records like so-called pseudomyxoma peritonei, and I thought, what does so-called mean? And then the word carcinomatosis would appear, and then my oncologist would say, but you don't really have that. And I said, well, why is it in this report? With someone who's been diagnosed for a long time, I can say this has been very distressing over the years, not to really be able to understand the framework really and the terms being used. And so I really am glad to see that we're moving towards a different way of describing this. I think patients will have so much of an easier time understanding their disease and why the treatment is being recommended in a certain pathway. And I think that this really has helped me understand why for 22 years it has been such a struggle really understanding what I have, you know. And so I thank you from the bottom of my heart, and I hope that this goes a long way in helping other patients have a much easier time.
Thanks, Charmaine. You echo thoughts from many of us here. There's no question, and I see the shaking heads in the audience today too. So I did want to give a couple reminders here as we near the end. And again, you can send emails to zoom@pmppals.net with any last questions. But just a couple of reminders. You know, we did see some survival curves in here today, and I just want to remind folks that I mean, we're having advances every year. You know, Bromac trial is just one of them, and each of our cases is individual. So we know patients on the full spectrum of disease who have had long-term survival. So remember that. We're grateful for the information for sure. Dr. Misdraji, another question came in. What percentages do we see across the grades? Like just off the cuff, what percentage of grade 1, 2, and 3 do you typically see?
I can only answer for my institution. I would say probably 80% of cases are going to be low-grade pseudomyxoma. And then the other ones, like I think signet ring cell is probably 10% and grade 2. The challenge I think with those, however, is that if we just restrict our conversation to pseudomyxoma of appendiceal origin, then probably those statistics would hold. I think if you started to incorporate pseudomyxoma from other cancers, like other organs like colon cancer and things like that, I think your percentages would be very different. I don't know, Laura, would you see a very different statistical spread?
I'm sorry, I missed the last question. I had to answer, somebody was waiting for me, but Chris,
the question is essentially what's the spread of low-grade, grade 1, 2, and 3 in pseudomyxoma in terms of percentages of the cases you're seeing?
Oh, yeah. Yeah, I think it's mostly low grade, and the vast majority are low grade that are getting referred to me. Now that also may be referral bias as well, you know, because the low grades obviously we're going to operate on more, and people with a higher grade will start on chemotherapy and they might not get to surgical consideration, but definitely the higher volume is the low grade.
Good. So there's a question I'm going to translate. Watch and wait is often something that is the right thing for patients to do. It's also difficult, emotionally hard, right, to know that we have this disease and that we're living with it. Can you talk about the role of watch and wait and how much you recommend that nowadays, Dr. Lambert?
Yeah, well, it depends on the circumstances, right? If somebody goes in for what's thought to be acute appendicitis, and the surgeon takes out the appendix and there's a low-grade mucinous neoplasm, and they saw a little bit of mucin in the abdomen that didn't have any cells in it, you know, that's somebody I would definitely watch and wait on, right? I'm not gonna, you know, it was just localized around the appendix in the right lower quadrant. Oftentimes those people will never need a surgery, and Dr. Misdraji has published on this as well. You know, on other circumstances, you know, especially when you're thinking about cytoreductive surgery and HIPEC, you know, I feel strongly that if I'm going to recommend that to somebody and take somebody to the operating room and put them through a big operation with heated chemotherapy and all the risk of complications in the recovery. I want to do it because I think it's, it's indicated and it's going to be helpful. And if we're really not seeing anything, and things, again, it's going to depend on the individual circumstances. I think it's okay to watch and wait as long as we're, we have a sense of the tumor biology. We know which category that tumor fits into, and we're going to be keeping a close eye on things. I'm not as worried that we're going to miss an opportunity, especially in a low grade, to treat for cure. And so I'm okay with watch and wait at that point. I do try to gauge it with the person's level of comfort for that, though, right? If if I really feel strongly that, or really feel confident that somebody's going to do very well and may never need the site reduction and the HIPEC, I might, but they're really uncomfortable with that, like watching and waiting. I might suggest, well, we'll do scans every so often, and then like at a year, let's put a camera in, let's put a laparoscope in and just look around and make sure it still looks good. And, a lot of times people will find that that's a good way to go about things and just, deal with that anxiety, which I know is real. I mean, it's real. But again, at the same time, we don't want to put people through surgery that puts people at risk. It's going to, knock them out, take away their quality of life for a period of time and not offer any real benefit, or hopefully any benefit.
What we recommend and advise as well, Dr. Lambert, and I think you'll agree with this, but I welcome feedback for sure, is, we are ultimately responsible for deciding on our own care. And even for us as caregivers and supporters, that can be difficult for us too, because sometimes people choose, I don't want to go through HIPEC, it's just too much. Mm-hmm. But, as people make their individual decisions and come to their conclusions, they may want HIPEC if they have a low-grade tumor. They may still say, I really want to do everything I can to try and get cured from this. And so we support patients and say, different surgeons have different approaches and different tolerances. And absolutely, I can reinforce what Dr. Lambert said. Our surgical oncologists are humans too, and they don't want to conduct surgery that they don't feel is going to be ultimately successful in the goals that you want. But if you really want that care, then I think you can seek multiple opinions and go seek that for yourself. And I see you shaking your head, Dr. Lambert.
Yeah. And I strongly encourage people to get different opinions. Sometimes I always warn them, you may get multiple different opinions and then you have to pick from one, and figure out which one feels right to you. But that's kind of what it comes down to, Chris, exactly what you were saying, is what feels right to me, what's going to give me the most peace of mind. Who do I, how do I relate to this surgeon? Do I trust that person? Do I really feel like they care about me? Is it a good fit for me and my family? And even location wise, right? I know people will travel around the country to seek opinions and stuff like that. And maybe somebody's got family in Seattle, and that's a really good reason to think about doing it in Seattle versus, staying closer to home, even if you've got the support that you need. All of that comes into play. This is a hugely emotional journey. There's no question. And just like you said, Chris, you have to advocate for yourself. Nobody's going to advocate for you more than you and your family are going to do that. And don't worry about like surgeons' opinions or hurting somebody's feelings or offending a medical oncologist or something like that. You have to do what's right for you and get the information that you need to make the right decision, the best decision for you and your family. And just don't worry if somebody gets offended, that's on them. You have to do what's right for you.
Amen.
Yes.
Reach it, sister.
Another question on a new patient seeing a specialist for the first time. Are there some specific questions that should be asked?
Yes, there's a lot.
Probably more time than we have for today.
I'm noticing that the list seems to be getting longer when I'm working with people. So I do know that the information is getting out there. I think if you're specifically talking about surgeons, I think it's helpful to know, people always ask me, how many of these have you done? How many do you do here at your institution? Are the people that are going to be taking care of me after the surgery familiar with the recovery? What resources do you have from the hospital, for my family? And You know, what do you know, ask about, you know, what's your rate of major complication? You know, if, you know, what's the rate of people dying from the surgery? I had one unfortunate person who was under the impression that the number of people who died was 50% who had the surgery. And she still signed up for it. And I was like, oh my goodness, you know, and I finally understood that. I realized why she was so anxious. And I was like, you know, if it was that high, I wouldn't do it. You know, if it was, you know, if every other person was going to die from the surgery. So, so ask, you know, ask those questions. If you have a question that's really causing you to have anxiety or fear, ask it, you know, and it's not a stupid question. It's, you know, it's a question. This, you know, as we've already heard today, getting information about this type of tumor is very hard, even for the providers, right? Even for the physicians who take care of people with this. So, you know, if it's a question that's bothering you, that you feel like it would be helpful for you to have the answer, ask it. I would just say ask it. And again, don't worry about offending anybody, and don't worry about looking, you know, stupid or anything like that. Just ask it.
Well, and Dr. Lambert, in the beginning, I was complimenting you as one of our favorites, but you really do understand the emotional and spiritual aspects of this journey in a different way than many of our specialists. And that's why we appreciate you so much. So it's a big deal. Thank you. And I'm seeing questions about, you know, specific cases and local surgeons who have done work. And I want to encourage you. I mean, we know patients, it's pretty common, unfortunately, in our story where local centers will do things maybe too aggressively, right hemicolectomies that aren't necessary or called for nowadays. And I mean, yes, you're going to go through an emotional process and deal with that loss and frustration, but it's still okay. You can still get to a specialist, and we would recommend that you get there as soon as possible. There is a page on pmppals.net called Find a Surgeon, and so you can look for surgeons on the Find a Surgeon page, and it's a Google map, so you can see where they're located and see who's closest to you. Are there any other questions, Adele? Or I think we're gonna.
Yeah, I think those are all that came in, but to echo the emotional resilience, I mean, it's all intertwined, and I think when you're newly diagnosed, the prospect of surgery or even being out for a few weeks sounds so long, but then in the big scheme of things, it's such a short period of time. So, but you know, getting the right information, feeling comfortable with your providers, and, you know, being, you know, having as much hope and support as possible, because you have your good days and your bad days.
And I would also add, you know, when you get a diagnosis like this, and probably everybody in this room knows that, you know, it just changes your whole world. And you've probably most people probably never had to deal with anything quite so earth-shattering. And it's very hard to deal with that emotionally, psychologically, spiritually. And I would strongly, strongly recommend that if you need help in those aspects, please seek the help that you need. There are great therapists who specialize in helping people who have just been diagnosed with cancer or going through the cancer journey. That's all they focus on. And they can just really provide a lot of help and guidance, because when you are facing a surgery like this, there's no question you have to be all in with your energy and your drive and your, you know, wanting to literally kind of like wanting to have the surgery because you know that it's going to help you, and you're just, you know, committed to it. And so if you're struggling with anything on that end of things, please get the help that you need. It is not a sign of weakness. You know, these are not normal circumstances. It's not a sign that there's anything wrong. It's just a normal human reaction to a life-threatening condition. And there are people who can help, and it can really help with your recovery and everything else afterwards. So just get the help. Again, advocate for yourself, get the help that you need, seek those resources.
Absolutely. We recommend getting a therapist on day one when you're diagnosed with this. I still work with one today. I've learned so much through that treatment modality as well. And I will, in closing, remind everyone that we do have programs that are solely for support. PMP PAL's mission since 1998 as our founder, Gabriella Graham, has taught us, is to provide hope and support for patients and caregivers. So that's what we do. We do have the Get Well Cards program. I'm showing my personal Get Well cards that I've received, and I still keep nearby, so I see them every day. We do have a starter kit that has important things like antibiotic and notepads and other things that you're going to need during the journey that you might not recognize now. When we wrap up the presentation, I will put up a slide so you can see the email addresses so you can access those particular programs, the Find a Surgeon program as well. So in closing, again, Dr. Misdraji, this has been absolutely fantastic. Thank you so much for taking the time to educate us this way. We really appreciate it. It's been fantastic. And Dr. Lambert, thank you for coming on short notice too. We're always glad to have you every time. And we'll say thanks again for being here. On Saturday, we are not going to have our normal support group because we've had this educational meeting today, but next Saturday on the regular time, we'll start up again. And that will be a high touch support group, as we often do. We're glad for these educational opportunities, but we'll see you. We'll see you next weekend. Thanks, everybody. Have a great night.
Yes, thank you so much.
Thanks, Adele. Thanks, everybody.
Bye, Laura.
Bye, Joe.
Good to see you, Dr. Lambert. Bye.
Bye.